Think about the last time your knee ached after a long walk, or your lower back seized up after an afternoon of yard work, or a headache settled in behind your eyes on a day you had no time to lie down and wait it out. You did what almost everyone over 60 does in that moment. You opened the cabinet, took two of whatever was in there, and moved on with your day. Maybe it was the same bottle you've reached for 100 times over the past decade. A name so familiar it barely registers as a medication anymore, more like a household item than a drug. You didn't call your doctor? You didn't think twice because nothing bad happened? The pain eased, you went back to your afternoon, and the pill bottle went back in the cabinet until the next ache came along. You have done this dozens of times, possibly hundreds across years, without a single moment of concern, because nobody ever told you that the relief you were getting from that bottle was arriving at a cost that your kidneys, quietly and without complaint, have been paying every single time. Your kidneys are two fist-sized organs that filter roughly 50 gallons of blood every single day. And they do this work through a network of nearly 1 million microscopic filtering units per kidney, called nephrons. Delicate structures that depend on a very specific, very consistent blood flow to function correctly. What most people never learn is that many of the most common over-the-counter and prescription pain medications work, in part, by narrowing the blood vessels that feed those nephrons, a mechanism that provides fast, effective pain relief in the joints and muscles while simultaneously reducing blood flow to an organ that cannot tolerate that reduction the way it could at 30 or 40. Dr. Sharon Moe, professor of medicine and director of nephrology at Indiana University School of Medicine and past president of the National Kidney Foundation, has written that the kidney's tolerance for pharmacological blood flow disruption declines measurably after age 60, as the nephron count itself has already fallen by a significant percentage through the ordinary course of aging, meaning the same dose of the same medication that produced no measurable effect at age 45 can produce meaningful, sometimes irreversible damage at age 65, 68, 72. Not because the drug changed, but because the organ receiving it did. There are 8 specific medications that this pattern applies to, some of which are sitting in your medicine cabinet right now. And each one damages the kidney through a distinct mechanism. Worse. The first and most widely used offender is ibuprofen, sold under the brand names Advil and Motrin, a non-steroidal anti-inflammatory drug so common that most people do not consider it a real medication requiring real caution. Ibuprofen works by blocking prostaglandin production throughout the body, which reduces the inflammation causing your pain. But prostaglandins also perform a critical function inside the kidney, keeping the blood vessels feeding the nephrons dilated and functioning normally, particularly during moments of mild dehydration or reduced blood volume that become more common with age. Block the prostaglandins, and in a kidney that is already relying on that dilation to compensate for age-related blood flow reduction, you can trigger a sudden drop in kidney filtration function known as acute kidney injury, a condition that in a younger patient often resolves completely once the drug is stopped, but that in an adult over 60, taken regularly over weeks or months, can leave behind a permanent reduction in kidney function that never fully returns to baseline. Research published in the American Journal of Kidney Diseases examining regular NSAID use in adults over 60 found a significantly elevated risk of chronic kidney disease progression among habitual users compared to non-users, with the risk rising sharply in those who were also taking blood pressure medication or had any pre-existing reduction in kidney filtration, a combination that describes an enormous share of the 60-plus population. The second is naproxen, sold as a lave, a close chemical relative of ibuprofen that operates through the identical prostaglandin blocking mechanism, but with a longer half-life in the bloodstream, meaning it stays active in the body and continues suppressing that protective kidney vessel dilation for significantly longer per dose than ibuprofen does. Dr. Mark Rosenberg, professor of medicine at the University of Minnesota and a former officer of the American Society of Nephrology, has documented that naproxen's extended half-life makes it a particularly common culprit in cases of NSAID-induced kidney injury discovered incidentally on routine blood work, precisely because patients taking it once or twice daily for arthritis pain assume that the lower dosing frequency compared to ibuprofen makes it gentler, when in reality the sustained blood concentration produces more continuous pressure on kidney blood flow across the full 24-hour period. The third is diclofenac, available over the counter as Voltaren gel and by prescription in oral form, frequently recommended specifically to older adults because the topical version is marketed as having lower systemic absorption and therefore lower risk. A claim that is only partially true. Oral diclofenac carries, according to a large cardiovascular and renal safety analysis published in the BMJ, one of the highest kidney and cardiovascular risk profiles of any NSAID on the market, a finding significant enough that several national health authorities have restricted its use in patients with any pre-existing kidney or heart risk factors, a category that includes a substantial share of adults over 60 who have never been told that the pain gel their doctor recommended has a systemic version carrying meaningfully elevated risk. The fourth is aspirin. Specifically at the higher anti-inflammatory doses, many older adults still take out of habit for joint pain, rather than the low 81 mg cardioprotective dose their doctor may have separately prescribed. A distinction. Many patients are not clearly aware they are conflating. At high doses, aspirin behaves pharmacologically like the other NSAIDs described here, suppressing the same protective prostaglandin pathway in the kidney. And Dr. Mo's research group at Indiana University has specifically flagged high-dose aspirin as an under-recognized contributor to kidney function decline in older adults, who believe that because a low dose of the same drug is heart healthy, a higher dose taken for pain must simply be more of a good thing. The fifth is celecoxib, sold as Celebrex, a selective COX-2 inhibitor originally developed and marketed specifically as a gentler alternative to traditional NSAIDs because it was designed to spare certain protective prostaglandins in the stomach lining. But research summarized by the National Kidney Foundation has clarified that this selectivity does not extend to the kidney, where COX-2 inhibition affects renal blood flow through a mechanism essentially parallel to ibuprofen and naproxen, meaning the drug's reputation as the safer NSAID applies specifically to gastrointestinal risk and not to kidney risk at all, a distinction that has led a considerable number of patients to take celecoxib in higher doses or for longer durations than they would have felt comfortable with ibuprofen, under the mistaken belief that the entire risk profile had been improved. The sixth is acetaminophen, sold as Tylenol, which operates through an entirely different mechanism than the 5 drugs already discussed and does not carry the same prostaglandin-mediated kidney blood flow risk, but carries its own distinct danger in the 60-plus population through chronic, high-dose, long-term use. Its metabolic byproducts accumulate in kidney tissue and have been associated, according to research published in the Clinical Journal of the American Society of Nephrology, with a condition called analgesic nephropathy, a slow, cumulative form of kidney damage historically documented in patients consuming acetaminophen daily in combination with other analgesics over a period of years, a pattern common among older adults managing chronic arthritis pain with layered combinations of medications from different cabinets, often without realizing how many separate products contain the same active ingredient simultaneously. The seventh is ketorolac, sold as Toradol, a powerful injectable and oral NSAID frequently administered in emergency rooms and urgent care clinics for acute pain because of its rapid and potent effect, a potency that comes with correspondingly potent kidney risk, severe enough that the FDA-mandated labeling explicitly limits its use to 5 days maximum and specifically flags patients over 65 as requiring dose reduction, a warning that a meaningful number of urgent care patients are never verbally given even as they receive the injection for a sprained ankle or a dental procedure. The eighth is the combination product Excedrin and similar caffeine aspirin acetaminophen blends, which layer 2 kidney-relevant compounds together in a single tablet, while the added caffeine component, according to research reviewed by the National Kidney Foundation, produces a mild diuretic effect that can compound dehydration, the exact physiological state described earlier in which NSAID-related kidney blood flow suppression becomes most dangerous. meaning the combination product can produce a compounding effect greater than either ingredient taken alone. Here is what to do with what you now understand about the 8 bottles that may be sitting in your own cabinet right now. Check the label of every pain reliever you have taken more than twice in the past month and identify whether it falls into the NSAID category, ibuprofen, naproxen, diclofenac, celecoxib, aspirin above 81 milligrams, or ketorolac, or the acetaminophen category. Because the safe long-term approach differs for each, request a basic metabolic panel and a calculation called the estimated glomerular filtration rate, or eGFR, at your next blood draw, specifically to establish your current kidney function as a baseline. Rather than waiting for a symptom to prompt the test, tell your physician by name every over-the-counter pain medication you take regularly, including combination products, since many patients only disclose prescription medications and leave out the cabinet staples they've taken for years without considering them medically relevant. Ask directly whether acetaminophen, taken at the correct dose, is a safer option for your specific situation than the NSAID you have been defaulting to. And if you are taking any of these 8 regularly for chronic pain, ask about non-pharmacological alternatives, physical therapy, topical capsaicin, or a referral to a pain management specialist before the relief you've relied on for years quietly costs you kidney function you cannot get back.